Hello, everyone. I'm just going to give a few more minutes for some people to drop in. Please leave your name in the chat just so I can keep it for attendance records, and then I'll send you the code after the CE is done. Can everyone hear me? I just want to make sure that my microphone is working. Again, if everyone can just put their name in the chat, just so I can keep track of it for attendance purposes. Sometimes your name doesn't come up, so I won't be able to mark you down. And I'll start in another minute or two. All right, I think I'm going to begin. So today I will be presenting, my name is Vincenza, as you all know, and today I will be presenting Hit Me With Your Best Shot, Management of Heparin-Induced Thrombocytopenia and Disseminated Intravascular Coagulation. So before we begin, I just want to mention that I have nothing to disclose. Some objectives that I hope to achieve today are to describe the pathophysiology of type 2 heparin-induced thrombocytopenia, which I will be commonly referring to as HIT throughout the duration of this presentation. Next, I'd like to identify the diagnostic criteria and testing used for diagnosis of HIT, to describe the pathophysiology of disseminated intravascular coagulation, or DIC, and to outline an optimal pharmacotherapeutic regimen for patients with acute, subacute, and remote HIT, with or without the presence of thrombosis. And lastly, I'd like to recognize conditions in which anticoagulants may be useful for patients with DIC. First, I'd like to get into the epidemiology and pathophysiology of type 2 HIT. So why is HIT so important? So heparin-induced thrombocytopenia is an adverse drug reaction mediated by platelet activating antibodies that target complexes of platelet factor 4 and heparin, or low molecular weight heparins. Given the fact that approximately 12 million inpatients are exposed to heparin annually, it is important to be cautious of the potential for thrombocytopenia. Patients with HIT are at markedly increased risk of thromboembolism, with an annual incidence rate of less than 0.1 to 7%. And this is generally due to the type of heparin. Usually unfractionated heparin has a higher risk. As you can see in the figure on the right, unfractionated heparin has a longer pentasaccharide sequence in comparison to low molecular weight heparin. It stimulates antithrombin 3, leading to inactivation of factors 2, 7, 9, 10, 11, and 12. And because of its smaller size, low molecular weight heparin does not interact with platelet factor 4 and platelets as efficiently as does unfractionated heparin. It's important to be able to recognize HIT and be able to appropriately manage it, given its mortality rate of about 20%, as well as the other negative consequences associated with it if it's left untreated. So now, just to get into the two subtypes of HIT. So there are two types. Type 1 HIT presents within the first 2 days after exposure to heparin, and the platelet count will generally normalize with continued heparin therapy. Type 1 HIT is a non-immune disorder that results from the direct effect of heparin on platelet activation and is generally clinically insignificant. Type 2 HIT, on the other hand, is an immune-mediated disorder that typically occurs 4 to 10 days after exposure to heparin and has life and limb-threatening thrombotic complications. Typically, it will occur after 5 to 10 days if there's no prior exposure. However, if the patient was previously exposed to heparin, HIT may occur within the same day. So it's important for me to make that distinction. So in general medical practice, the term HIT will refer to type 2 HIT. So this will be our primary focus today, just to let you guys know. So we give a patient heparin. How does the formation of these antibodies occur? So heparin will interact with platelet factor 4 in some patients, about 2% or 1 to 5% forming the heparin platelet factor 4 complex. And this complex is foreign to our body and will get recognized by your immune system, specifically IgG. Moving on to step 2 here, IgG, which is the antibody that gets released from our B cells, will end up targeting this heparin platelet factor 4 complex. And the immune complex will bind to the Fc receptors on the platelet to activate it, leading to increased platelet aggregation and release of procoagulant microparticles, leading to thrombosis. If it's left untreated, it will lead to prothrombotic state, causing many complications, including this thrombocytopenia and thrombosis. The two main manifestations of HIT are its thrombocytopenia and thrombosis, and HIT with thrombosis will lead to amputations, post-thrombotic syndrome, and or death potentially. Thrombosis will occur in 1/3 to 1/2 of patients with HIT and may be venous, arterial, or microvascular in nature. Rates of amputation are 1 to 3%, and rates of death associated with HIT are 5 to 10%. Although HIT is associated with a decrease in platelet count, as its name does imply, clinically significant bleeding at presentation is uncommon, as these patients actually have a more increased tendency to thrombose or clot. And a diagnosis is typically made by a compatible clinical picture, an unexplained drop in platelet counts as defined as greater than a 50% drop from baseline, and laboratory confirmation of antibodies or platelet activation. So I included the most common risk factors for the development of HIT based on the statistics from certain studies. Per the results of these findings, strong risk factors for HIT include the indication for treatment. So typically surgical patients are at a higher risk in comparison to medical patients with an odds ratio of 3.25% and a statistically significant confidence interval. The sex of the patient is also important, as females are said to have more of a 2 times higher risk of developing HIT with unfractionated heparin in comparison to males. Older age is said to be a risk factor for HIT. However, the findings are very limited, but I did think it was pertinent to include. Also, the dosing of the heparin is also a big risk factor for HIT. So typically therapeutic versus prophylactic dosing, it's higher in therapeutic dosing. And again, unfractionated heparin has a much higher risk of developing HIT in comparison to low molecular weight heparin. As you can see, the incidence rates 2.6 versus 0.2%. It's a pretty significant rate there. So now to get into the diagnostic criteria. So diagnosis of HIT involves both laboratory and clinical components to determine whether it is HIT or thrombocytopenia occurring from a differential diagnosis. So when a patient presents with suspected HIT, we utilize the 4T score to evaluate for the degree of thrombocytopenia, timing of platelet decline after heparin administration, presence of a thrombus or other HIT sequelae, and the probability for other thrombocytopenic causes. So this scoring system has a high negative predictive value, making it very useful to diagnose HIT. And the 4T score is the sum of these values for each of these 4 categories. So we calculated the 4T score. Where do we go from here? So scores of 0 to 3, 4 to 5, and 6 to 8 are considered to correspond to a low, intermediate, and high probability of HIT, respectively. I included this quick reference guide for your reference. So for example, if the patient scores between 4 to 5, they're classified as having an intermediate probability. In this case, we should discontinue heparin, perform an immunoassay and a functional assay. And if the results of the immunoassay is positive, we should avoid heparin and continue with a non-heparin anticoagulant. And we'll get into these alternative options as we move forward. Next, I have an assessment question for you all. Patient AB's platelet count has fallen 60% from baseline since initiating heparin 11 days ago. She currently has no evidence of thrombosis and no other cause for thrombocytopenia. The team suspects HIT and calculates her 4T score to be 3. What likelihood does this patient have for developing HIT? Based on her 4T score, what is the most appropriate thing to do next? And I'll give everyone a minute to respond. You can just drop your answer in the chat. Anyone? Okay, so the answer here is low, given the fact that the patient has a 4T score of 3, which correlates to a low risk. There is no need to discontinue heparin or perform additional laboratory testing as per the previous chart. So now to discuss the different assays used in the diagnosis of HIT. So there's different immunoassays and functional assays that are available. The choice of assay may be influenced by diagnostic accuracy, availability, cost, feasibility, and turnaround time. The ELISA, or the enzyme-linked immunosorbent assay, is a plate-based assay technique designed for detecting and quantifying soluble substances such as peptides, proteins, antibodies, and hormones. In an ELISA, the antigen, or the target macromolecule, is immobilized on a solid surface and then complexed with an antibody that is linked to a reporter enzyme. An enzyme-linked immunosorbent assay using a complex of heparin and platelet factor 4 is used to capture the antibody developed